But the exact steps that are causing that, are not understood in every different type of sarcoma. I can just give you a simplistic answer. More unstable DNA, more mutations, driving a more aggressive biological process.
Can hypoxia be the cause for inducing the mutation?
Yeah, so I can't say, some people have hypothesized that. Again, we don't know. I would say yes, it may be. We don't know yet. This is something that we'll understand in the upcoming decade. Nope.
Some strategies that people are looking at to determine what might be potential cause for dedifferentiation or for
So looking at the low-grade sarcoma, the high-grade sarcoma, gene expression arrays to understand what proteins are now being produced, looking at the...
Show up in my office with an MRI scan, like, oh, what is this? And I can't tell. And then you get an X-ray and you can see the mineralization of an enchondroma, but they thought it was a sarcoma just by looking at the MRI scan. So we're going to talk a lot about bone radiology. Now, with bone radiology in plain films, you have to have a systemic approach. With a systematic approach, you got to look for certain things in analyzing the X-ray. Too often, and I've known some very famous radiologists that usually say, well, if it looks like your Aunt Minnie, it must be Aunt Minnie. Well, if you don't know what your Aunt Minnie looks like, you have no idea of figuring it out. And if you're that brilliant and you've seen that many X-rays, you might be able to do that. But most of us are not in that situation, so what we need to do is analyze the X-rays systematically, and you can usually come up, whether it's benign or malignant, and narrow it down to usually a diagnosis of 2 or 3. And I think that you should be, 80% of the time, should be in your differential of 3 when you narrow it down as you go through it. Now, understanding musculoskeletal radiology is only part of the battle. In order to make a diagnosis, not only do you have to have good knowledge of radiology, but you need clinical information. You should never, never try to come up with a differential diagnosis without having some clinical information beforehand. And Dr. Rosenberg would never give you a pathologic diagnosis without the radiologic information. So we'll start off as some of the clinical information that's important to know is the age. You certainly wouldn't be thinking of a metastatic carcinoma in a 5-year-old, nor would you be thinking about a simple bone cyst in an 80-year-old. So age is very important to analyze in the radiology, and symptoms. And why is symptoms important? Is because a painful bone lesion should be a red flag. Most painful bone lesions are malignant tumors. There's only a few benign tumors that are painful, chondroblastoma or osteoid osteoma. Other than that, most benign bone tumors aren't painful, so a painful bone tumor ought to be a red flag for a malignancy. Other things that we're going to go through in quite a lot of detail is size of the tumor, bone patterns, which we're going to focus a lot on bone patterns, periosteal reactions, and location. So let's start off with the age. Age is important, and you got to know which age groups that you're dealing with. And so I think that first of all, you have to have several groups of patients that you need to be thinking of that bone tumors commonly occur. And when you look at under the age of 10, what are we thinking of? Simple bone cyst, eosinophilic granuloma, or the malignant tumors such as Ewing sarcoma or leukemia. Those are the under age 10. When you look at patients 10 to 20, almost all tumors occur between 10 and 20. That's your most common age group. That's when, as Dr. Rosenberg was saying, that the bone is growing so rapidly and all sorts of things occur, causing the neoplasms to occur. So at 10 to 20, you've got non-ossifying fibroma, aneurysm, bone cysts, all the way down to chondroblastoma, most benign things. And malignant tumors, we're talking about osteosarcoma and Ewing sarcoma predominantly, and adamantinoma starts coming into play. When we look at 20 to 40 years of age group, this is an age group that your differential narrows down some. Giant cell tumor always comes along with that benign tumor, that age 30. Other benign tumors or enchondromas are beginning to show up, and the malignant counterpart are chondrosarcoma. And metastatic tumors begin to show up at the later age of 40. But when you get 40 above, that's when we're thinking of metastatic cancer. That's the most common bone tumor that we're going to see, or malignant bone tumor. The benign bone tumors are osteomas and many, many enchondromas. My clinic is filled with benign cartilage tumors. So, but the malignant tumors you're thinking of are metastatic disease, myeloma, chondrosarcoma, secondary osteosarcoma. As Dr. Rosenberg says, that second hump in the osteosarcomas that you see are usually secondary osteosarcomas. Now, this is a very, very important picture because with this picture, there's certain elements there that are going to tell the difference between benign and malignant neoplasms. And so what we first talk about is the zone of transition. Benign tumors have a very narrow zone of transition. The body's almost walled them off. Whereas a malignant tumor has a very wide zone of transition. It's growing so rapidly, the bone can't respond to it. As Dr. Rosenberg said, the bone responds to stimuli and stress. They respond to neoplasms. And so a fast-growing neoplasms, the bone has a difficult time of walling it off. Whereas a slow-growing neoplasm, the body tends to wall them off very easily. We'll then talk about periosteal reactions. And not a lot's been written about periosteal reactions. But periosteal reactions give enormous amounts of information between benign and malignant periosteal reactions. And we'll be talking a little bit about that. First of all, we're going to talk about bone patterns. Most of the bone patterns that we talk about were developed by Dr. Lodwick. Lodwick was a radiologist in Kansas, and he was nominated for the Nobel Prize of what he talked about with imaging of bone tumors. And specifically, the Lodwick classification is used quite often by bone radiologists. Although the way he initially described it is not how we normally use it today. Lodwick's classification really talked about malignant tumors. He went to the NCI and looked at all these 2,000 malignant tumors and graded the malignant tumors based off of this classification. Now, we use the Lodwick classification to define the difference between benign and malignant. And it's very nice with type 1 lesion, you have the A, B, and C, the well-defined with sclerosis, well-defined with no sclerosis, or ill-defined but still geographic. Then you have moth-eaten and permeative, which are more your malignant tumors. Well, working with Dr. Kransdorf, who's a very, very famous musculoskeletal radiologist from Mayo Clinic, we did some work and we analyzed a bunch of x-rays, and we kind of redid the Lodwick classification, and we've submitted for publication. And so we've got our own bone tumor radiologic classification system, which makes it a little bit more easier and actually subdivides between benign and malignancy much nicer, between 1 with classification 3 and 2 and 3. We've divided it into 3 different major categories with 2 subdivisions of each one. And so when we look at this, what we're doing with our classification system is a classification of 1. The class 1 bone tumors are predominantly benign. And a 1 is a 1A, which the body is walled off. There's a nice sclerotic border. That means that tumor is growing so slowly, the body has begun to form a rim of bone around the outside of that. So those are predominantly benign bone tumors, such as non-ossifying fibromas. A 1B is, it's very geographic, well-defined, but there's no sclerotic rim, such as a giant cell tumor commonly occurs with these type. Then you have a type 2A. So when you go from 1 to 2, you have an increased chance of malignancy. The type 2 have almost a 50-50 chance of being malignant. That means it's geographic with a wide zone of transition. It's difficult to tell where that tumor starts and stops. And in type 2B means a changing margin. And what that means is, although it's geographic most of the way around, all of a sudden something has happened. The tumor has become more aggressive and it's breaking down that barrier. And that changing margin increases the risk of malignancy. When you get to the stage 3, or the class 3 lesions, these are predominantly malignant tumors, where a 3A is a moth-eaten, these punched out holes in the bone, but still a very wide zone of transition. down to the primitive, which the tumor is growing so fast, there's just little teeny tiny holes punched out in the bone as the tumor permeates rapidly through the bone. And a type 3, or a 3C, Dr. Kransdorf's designation, he's much smarter than I am. That means the tumor is growing so fast you really don't even see it on the plain films. You might see a periosteal reaction, but more commonly you see it on the MRI scan. Those are the fastest growing tumors. Now, we took all these tumors and we used this classification system, and we then analyzed several hundred patients. So when we did this, we then looked at malignant tumors, and you can see malignant tumors were very rare in the class 1, equally distributed in the class 2, but once you got to a class 3, over 90% of these were all malignant. So if you can classify the tumor into this system, you have a high probability of deciding between benign and malignant. And when we looked at the benign tumors, they graphed out very, very systematically in that benign tumors are predominantly a class 1 tumor. So we'll go through this a little bit. And so we'll start first talking about grade 1 tumors. And remember, a 1A lesion has always been benign in the group of tumors that we looked at. And a 1B is predominantly benign also. So here you can see a plain X-ray with a well-mineralized rim around the outside. You can see how it's walled off very nicely. You can see on the CT scan, it's walled off in that endosteal rimming. That means a very slow-growing tumor. When you look at this, you may not know what that is, but we know it's benign, and this is actually a 1A lesion, which was a chondromyxofibroma. So here's a lesion that's very well defined, geographic, but there's no sclerotic rim around the outside, and you can see in the CT scan there's no rim. And this is a faster growing benign tumor, giant cell tumor, which is anywhere from a Anakin 2 to a 3, a slow to fast growing benign neoplasm, and that, when we classify that out, that's a 1B lesion. So as we move along to the class 2 lesions, now our risk of malignancy begins to increase. And so here you can see a geographic lesion, but where does that lesion start and stop? Once you get an MRI scan, it looks a little wider than what you see here. So this is a wide zone of transition, geographic, and so this is what we call a 2A, and this is actually a very low-grade malignant tumor. This is a clear cell chondrosarcoma, low-grade malignant tumor with that wide zone of transition. Now here's an interesting case. If you would look at this just at a glance, you would say it's a 1A lesion, right? There's a mineralized rim. That means this is growing so slowly the body's walled it off. So we know that's got to be benign. But if you look a little closer, there's a break in the cortex there. And you look at the MRI scan, there's a soft tissue mass. So this was a benign neoplasm for some period of time. It's undergone a change to a malignancy. And this is what we call a 2B, or a changing margin. We get to grade 3 lesions. Grade 3 lesions are predominantly malignant tumors. And so we look at grade 3 lesions. Here is a moth-eaten appearance. And you can see that that tumor is extending much farther up the canal than you would originally visualize from the X-ray. And that would be a 3A, or moth-eaten. Then we have a permeative lesion, which we call a 3B, and you can see that there's a very rapidly growing permeative appearance on the X-ray, but by the MRI scan, this tumor is extending much farther up and down that canal than you can see on the X-ray, and that's an example of a 3B, or permeative appearance. And then this is what Dr. Kransdorf calls an invisible tumor, or an invisible margin. If you look at the X-ray, you'd be hard-pressed to say there's any tumor there at all. But by the MRI scan, you can see that there's marrow changes going on inside the bone. There's a lymph node there. This was actually a lymphoma bone, but we all call that an invisible margin. And that's your more rapidly growing tumors. So we're going to just go through some unknowns, some examples using this classification system here. And so when you look at this, we know that there's a 1A margin here, right? You can see that nice mineralized rim around the outside. It's a 1A margin. But what is that? When you look at the CT scan, you can see that that's a defect in the cortex. That's a fibrous cortical defect. geographic 1A. So here you can see a lesion that looks like rather large holes punched out in the bone. And when you look at that, there's a large soft tissue mass associated with that, and that would be a 3A or a moth-eaten appearance, which was a osteogenic sarcoma. Here's an example of a geographic lesion here. Where's that zone of transition? Does it end here? Does it end there? It's a pretty wide zone of transition, and you can see it comes all the way across the bone. So we would call that a 2A. This is actually a giant cell tumor. Again, one of the more rapidly growing benign neoplasms. So here we can see an X-ray, and most of us would take a glance at that and say, well, this is a cartilage tumor. Must be an enchondroma. But that looks a little bit thickened over here. If you actually look at the CT scan, there's a break in the cortex. This is what we call a changing margin, and a changing margin is a malignant tumor, and this actually was a dedifferentiated chondrosarcoma. All right, here's just another example of a lesion within the bone there. It's very permeative, growing very rapidly through the bone. You can see in the MRI scan extends quite distally up and down the canal. That's a permeative lesion. This is an example of a lymphoma of bone. Now, another thing that Lodwick did is his classification, if you read his article, was on radiolucencies. We apply this classification to radiodensities or radiolucencies. You can apply to either one of them. And you can see here, here's a well-delineated mineralizing lesion of the tibia. You can see it's geographic. The borders are very obvious, but it's not being walled off. It doesn't have a sclerotic rim around the outside. And here you can see the CAT scan, no sclerotic rim, but it's certainly a geographic lesion, and you can classify that as a 1B, and this is a giant bone island. But we knew it was benign. We might not have known what it was because it followed the classification system. All right, now we're going to focus going from the zones of transition to the periosteal reactions. Periosteal reactions are very important, and you can learn a lot by the periosteal reactions, and it gives you a lot of information about what's going on. Periosteal reactions was first described really by Professor Codman. He was an orthopedist from Harvard, and he talked really about the Codman's angle. And what that meant is that there was a Codman's angle or Codman's triangle that the tumor was growing so rapidly it lifted up the periosteum. The periosteum only knows to do one thing, it forms bone. So as the tumor continues to grow, it then breaks through the periosteum. So this is actually normal bone formation, but as it continues to grow, it breaks through that periosteum. There's a break in the periosteal reaction, and that usually means there's a malignancy. Continuous periosteal reactions are benign. This is what Codman described. Later on, Drysdale, in a textbook, described multiple different types of periosteal reactions, but there's really been no article specifically written about periosteal reactions. We always talk about them in Drysdale's information. In fact, we're writing a paper right now on periosteal reactions, and we've been classifying them, and I'll go through this classification we use. There's only two grades of this. There's either grade 1 or 2. 1 is benign, and 2 is malignant. Makes it pretty straightforward. So when you look at the continuous periosteal reactions, that means benign tumors, for the most part, always have a continuous periosteal reaction. You can follow it all the way along the way. And so if the cortex is intact, you can have a solid periosteal reaction or a single lamina, but it's a continuous periosteal reaction, and the cortex is intact. That's the most benign appearing periosteal reaction. If the cortex is disrupted here, but there's still a continuous periosteal reaction, that's another benign periosteal reaction, but a more aggressive periosteal reaction. Sometimes you see an aneurysmal bone cyst. The grade 2 or malignant periosteal reactions, what that means, there's a break in the periosteum. So it's an incontinuous periosteal reaction, most commonly a malignant. And with the single reactions, you can have anywhere from a Codman's angle to a laminated, which is onion skinning, or hair on end appearance. The most aggressive periosteal reaction that you see are complex periosteal reactions, where you see multiple periosteal reactions at one time, or whenever you see a divergent or sunburst periosteal reaction, those are always malignant. And so that would be a type 2B. So we'll go through these. Here's just a good example of a solid periosteal reaction of an osteoid osteoma. Very benign lesion, and that means the periosteum is elevated up, and over a period of time it's filled in with bone underneath there, but it's a benign periosteal reaction. Here's an example of a single lamina, but there's a continuous periosteal reaction. You can follow it all the way along the way. This is an osteomyelitis. Again, that's growing faster. The periosteum has been elevated up, but it's a continuous periosteal reaction because infections occur so fast there's not much bone that's formed underneath that. Here you can see a continuous periosteal reaction with a break in the cortex. I mean, this is a more active neoplasm. This is an aneurysmal bone cyst, but you can see there's a continuous periosteal reaction and there's a soap bubble appearance to it. Here's another continuous periosteal reaction. There's a break in the cortex, but this is a shell-like of a non-ossifying fibroma. Now we'll go through some of the periosteal reactions that are malignant periosteal reactions. We'll go through the single type first, which is the Codman's angle here. Periosteum is elevated up. There's this bone formed underneath there. And here's the laminated appearance. You can see this what we call onion skinning. The tumor elevates the periosteum, it begins to form bone again. Then there's another elevation of the periosteum, bone formation again, another elevation. And those continuous elevations cause this onion skinning appearance, which is more commonly in Ewing sarcoma. Here's a hair on end appearance. So the tumor is growing so rapidly, it lifts up the periosteum, and you get this hair on end appearance of this periosteal reaction. It's a broken periosteal reaction, and usually you see an osteogenic sarcoma. Now, here's the grade 2B, which are complex reactions. You see more than one reaction here. You see a sunburst, a Codman's angle, a laminated approach. Whenever you see these complex periosteal reactions, more than one type, these are predominantly always going to be malignant tumors. All right, so we'll give some examples of these. So here you can see there's this onion skinning appearance here. There's a Codman's angle here. There's a soft tissue mass that you can see. Again, that's a 2B. That's more than one type of broken periosteal reaction. Here you can see a periosteal reaction that's continuous. You can see the periosteum elevated all the way along the way, and there's filling in. So this is a solid periosteal reaction. We know this is a benign periosteal reaction, but what is it? That's actually a chronic osteomyelitis. But it follows that benign periosteal reaction. Here you can see multiple complex periosteal reaction, and that's a class 2B, and obviously that's a malignant tumor. Now, Mencken talks about, and I spent a year with Dr. Mencken, he talks about there's 4 characteristics you need to look for in analyzing a tumor. Is the lesion big or small? Which is obvious. The big tumors are more likely malignant. The small tumors are more likely benign. So it follows with it. Is the lesion well marginated? Well, we've been talking about that with the bone patterns. Is the cortex intact? Again, we've been talking about that with these bone patterns. And is there a soft tissue mass? Again, we've been talking about that with the periosteal reaction. So the rest of this follows through what we've really already discussed. Now, Dr. Mencken always talked about the matrices too. So you can have an ossification matrix, which is more the cumulus cloud type of matrix of bone-forming tumors. You can see calcification with these little stippled mineralization, little dots, and arcs and rings of cartilage. Or you can have that ground glass appearance of fibrous. So there's 3 specific types of mineralization patterns that we can go from the bone patterns of periosteal reactions to now getting a little bit more clues of whether it's benign or malignant now to what type of tumor it is. Here you can see this cumulus cloud bone formation, even cumulus cloud bone formation in the soft tissues of an osteogenic sarcoma. Here you can see, and I put the CT scan next to it, these stippled mineralization, but look at these rings, these arcs. Another ring, another ring, another arc. Arcs and rings of cartilage. Makes it very easy that we know that this is a benign cartilage tumor or enchondroma. And here you can see this fibrous ground glass appearance of a fibrous dysplasia. And it comes in many forms. This is the classic form, but here you can see all that blurring in of the bone of a fibrous lesion of a ground glass fibrous dysplasia. Now, Anna King he was another brilliant radiologist, and I got to study with him a little bit too. And what he talked about is 4 different categories that he looks at on bone radiology. And what he focused it really on the anatomic location, meaning tumors occur in specific locations. These other 4 we've already discussed, but what he talks about, you can narrow down the type of tumor depending on the location. This location is important because that's my Keys course. We know that's a very important location, and we know that that's where we always do our tumor course every year. But location is important when you look at in the tibia. Tumors that form in the anterior aspect of the tibia are usually adamantinomas. If you see a tumor with a soft tissue mass in the sacrum, what do we think of? Chordomas, right? And then when you see a tumor in the epiphysis, there's got to be 3 things. It's either chondroblastoma, giant cell tumor, or clear cell chondrosarcoma. Those are your epiphyseal neoplasms. So if it's epiphyseal, it narrows down your differential diagnosis. Now also I like to use location in narrowing down because tumors occur within certain areas of the bone. So if you know which areas within the bone that the tumor is occurring, you can narrow down the diagnosis also. Centrally occurring lesions or simple bone cysts, cartilage tumors, and fibrous tumors all occur centrally in the bone. So when you look at the bone radiology and you look at the location of it, it can narrow down the diagnosis. Eccentrically occurring tumors are epiphyseal and eccentrically occurring as giant cell tumor. Fibrous cortical defect is actually a defect in the cortex. They're very eccentrically placed. Aneurysm bone cyst begins in the cortex and grows into the marrow and into the soft tissues. Chondromyxofibroma are again eccentrically placed, and osteomas are cortically based lesions. So we'll finish up and we'll go through some examples of these. Here's an obviously centrally located lesion with a falling leaf sign, a stir image with water. We know that that's a simple bone cyst. If we look at this, we know that this is a centrally occurring lesion. What is centrally occurring lesion? Cartilage tumors. So we know that there's arcs and rings of cartilage, and this is a arc, there's a ring, and we know that's an enchondroma. When we look at this is a centrally occurring lesion, and it's kind of a blurring of the bone. You can see on the CT scan, it looks like that ground glass appearance. Again, centrally located. MRI scan shows low signal on each one of the scans, very hot on bone scan. We know that's a fibrous dysplasia. When we look at lesions that eccentrically occur in the epiphysis, in epiphyseal metaphyseal areas, we know that these are giant cell tumors, very classic. Again, if you look at the bone pattern there, that's a geographic area, and it's giant cell tumor. Here's a lesion that, if you look at it and say, well, is that centrally located? Well, it's only a 2-dimensional X-ray. But we know that's eccentrically located. We know that that's a 1A border, and we know that this is a defect in the cortex, and this is consistent with a fibrous cortical defect. Again, following the location on the bone is so critical. Here's a defect in the bone. Started in the cortex of the bone, right? And it's extended into the marrow and into the soft tissues. It's got a continuous periosteal reaction around the outside, so we know it's a benign periosteal reaction. We know it's a geographic 1B lesion, that's benign. And then if you look at the MRI scan, you see fluid levels, and we know this is an aneurysmal bone cyst. See, bone radiology is very easy when you start applying principles to it. Here we had a lesion we talked about earlier today. There's a 1A border, and we know that there's a very high signal here on the stir-weighted image, which is consistent with fluid or myxomatous tissue, and this is consistent with chondromyxofibroma. They most commonly occur in the proximal tibia, and they're eccentrically placed in the bone. And if you know that, you can narrow down your diagnosis to CMF. Here's a lesion that's eccentrically placed on the surface of the bone. We know that that's a solid continuous periosteal reaction, a simple nidus in the center of that. This is consistent with an osteoid osteoma, benign neoplasm, and makes this all very easy. So again, I'm trying to apply these principles that makes bone radiology very, very easy. And once you use what I call this systematic approach, you really can narrow things down to benign and malignant and usually narrow down what the diagnosis is. But just about 80% of the time. Any questions? Yes? Okay, we'll do the CT and MRI. All right.
Do is I'm going to look at this a little bit from the perspective of an orthopedic surgeon. And because when I look at it as a radiologist, I start talking about all sorts of stupid things that nobody cares about. And when I look at it from the perspective of an orthopedic surgeon, it all starts to make sense. So for those of you who are not radiologists here, for those of you who are radiologists here, I would just sort of ask you to pay attention to that. Now, I think the questions that I get asked most of the time when we do an MR or a CT or an ultrasound, the questions are, one is there a lesion? Is it more conspicuous? Can you make it more conspicuous? Can you give me a better idea of where that lesion is? How big is it and where is it going? Is it just in that spot, or are there multiple other areas in which this lesion is also that I need to be aware of? I want to know the extent of this lesion. Is it just within the bone? Has it gone outside of bone? If it's gone outside of bone, what are the structures it's encased or involved? Then they usually ask me, what is this lesion itself? Does it contain fat? Does it contain some other solid stuff? What are the contents of the lesion? Tell me what you can about what the nature of this lesion is so I know what I'm getting into. Can you give me a sense for what the tempo of this lesion is? Is this a fast-growing lesion? Is this a slow-growing lesion? Is this something that's just sort of around there? Tell me if I'm going to put a needle into it, or if I'm going to ask you to put a needle into it, where will you put a needle into it so that I can make it, so that I can be sure that we're going to get good tissue that's going to give us a diagnosis. And then finally, once I've already played around with this lesion, you need to tell me whether it's the same, it's changed, and what's happened to it. And if I've stuck metal into it or done anything else to it, can you do anything to help me? So in terms of what techniques we are going to discuss on this talk, we're going to talk about CT, ultrasound, and MR. And I think the one thing that I try to explain to people in terms of how CT differentiates you from radiographs is that if you were to think about yourself looking at a forest and you were sitting in a helicopter and looking down on that forest, then that's what you do when you're looking at it with an X-ray. You're getting a global view. You get to see where the fires are, you get to see where the hills are, you get a really good idea of the lay of the land, and that gives you a really good idea of what's going on. But when you're looking at CT, what you're trying to do is you're actually trying to walk into that forest, you're trying to look at each of those trees in a different way, and you're trying to understand what each of those trees is doing. So it does give you more detail. It's obviously CT angiography with contrast is very good for assessing vascular structures, and it's obviously the prime tool that we use today for image-guided biopsies of bone lesions, because you're sure you're in the lesion. You can be even sure in a three-dimensional way where exactly within that lesion you are, and most importantly, medico-legally, you can actually document it really well that you are in that portion of the lesion. Ultrasound is something that unfortunately has not been used as much as it should be used. It's user-dependent, and that's why people don't use it as much. But it's an excellent, excellent tool that's available for looking at bone and soft tissue lesions. Fortunately, a lot of the musculoskeletal system is superficial and easily accessible to ultrasound, so we can identify lesions well with it. We can look at diagnosing what they are. We can actually get a sense of what the content of these lesions is. And most importantly, I think it's an excellent tool. A lot of biopsies get converted from CT to ultrasound if you have a sonologist available who knows what they're doing, and you can stick needles into these lesions much more quickly, much more efficiently, and actually in some parts of the world it can actually become an office procedure instead of taking somebody to a CT scanner and doing all the other stuff. MR helps us to look more at the morphology and edema and other factors associated with bone lesions. It can obviously give us a better idea of soft tissue involvement and of response assessment. So just to give you a sense of where we go with this. So you have a lesion here, you have a patient here who has a backache, and you're not really sure what's going on. You get an X-ray, and again, you're sort of just looking at this, and nothing's really jumping out at anybody. You look at the patient himself, he's got a little bit of a scoliotic deformity, and you just sort of again go back and take another look at that radiograph, and you're sort of wondering, is there a pedicle here that looks a little more sclerotic than the rest? I don't know. He's pointed out the area of pain, and then here you can see clearly that there is increased sclerosis in this pedicle. And again, this is something that becomes a little bit hard to diagnose, and again, it's become conspicuous, but maybe not as conspicuous as one would like. And then you go on to do an MR, and you can see here how there's bone edema associated with it. and you can make the lesion even more conspicuous. So using various techniques, what we've essentially done is taken a lesion and made it more and more conspicuous, more and more evident for us, and that way we can go back and try and identify what this lesion is. And this turned out to be an osteoid osteoma. Again, you have a radiograph here with the shoulder. This is a patient who had shoulder pain, and nobody could really say much on the X-ray. When you do the MR, it becomes really quite clear how there is a lesion sitting in the cortex here with extensive bone edema surrounding it, and this was another osteoid osteoma. We have a patient here who had actually a lot of hip pain, and again, the radiograph's really not showing anything. A CT was done, and really nothing jumped out at anybody at the first step. Of course, those of you who are experienced have already picked the finding. We did an MR, and again here there's a little bit of bone edema on this side, and you wonder what's going on. And you're still sort of playing around with, is there a lesion or not? And they did a bone scan, and you can see it's intensely hot in that acetabulum. When you go back, that bone edema becomes far more evident, and when you go back and look at it a little bit more closely, you can see that this patient actually has a subtle little osteoid osteoma in the acetabulum. So again, the role of advanced imaging is to make abnormalities more evident, but it also helps you in terms of once you make an abnormality more evident, it confirms that there's a presence of something wrong, and it allows you to go back to the more simple imaging, relook at it, and identify something more closely. Now, when we talk about increasing lesion conspicuity, we talk about using various techniques. So CT, MR, ultrasound, these are tools available to us. But the other thing that we do is within MR as a modality itself, what we're doing is we're applying different pulse sequences. And what these pulse sequences do is they highlight those structures that have greater quantities of water as opposed to those areas that have lesser quantity of water. Once we give contrast, they give us an idea of those things that enhance and don't enhance. So using an interplay between these various imaging techniques, you can actually make a lesion more conspicuous itself. So when you do an MR, it's very important for you to look at all the sequences because one sequence will make a lesion far more conspicuous than another. So for example, if we look at this T1 weighted image or this proton density image, on this T1 weighted image, it looks like this pubic symphysis is almost normal. And when we look at this one, you can tell that there is a small rounded lesion here. When we look at this T2 weighted image, which is this plain T2 weighted image, again, we see the lesion here. But when we look at this T2 fat suppressed image, it becomes very clear that there's a lesion here. So using various MR sequences, one can make certain lesions more conspicuous, and that conspicuity is dependent upon the biology of the lesion itself. Does it contain water? Is it sclerotic? Does it contain cells? Does it contain chondroid tissue? And all these things will make a lesion more conspicuous. You also look at this, we've seen a radiograph like this earlier, where you see this lesion, it looks very chondroid. Of course, here it's very gross that there is some destruction of that normal chondroid matrix here. But on an MR, you can tell that it's not just a simple chondroid lesion, but it's got some periosteal reaction, periosteal edema here. And so here you're able to take it a step further from calling something a simple chondroid lesion. When you do an MR, you're able to tell that there's something else happening to this lesion that has caused it to change its normal pattern or it's progressed into something else. Another lesion here, so this is an osteosarcoma in the proximal tibia. You can see the lesion extend up to this point, and you're not really sure where exactly. You see a little bit of a Codman's triangle down here. You're not entirely sure where this lesion extends, and for a surgeon, it's very discerning. It's very disconcerting that they don't know how far down they have to go and operate or intervene. And that's where something like an MR would come into use. You would see the lesion more conspicuously. If you give contrast, the lesion gets much better outlined and the edema extends beyond it. And if you see this, a bone scan, you can see how the lesion is sort of relatively more well contained. So again, we're giving a better sense of what the dimensions of these lesions are, what the extent of these lesions are. So just again to give a sense of perspective in terms of what the differences would be between a radiograph, a CT, and an MR. When you look at this radiograph, you can obviously see a well-corticated geographic appearing lesion. On the radiograph, you would sense that this posterior cortex looks relatively intact. But when you look a little bit carefully into the CT, you see there's a large defect in the cortex. You feel that there might be a soft tissue component. You're not really sure where it's going. And you do an MR, you get a really good idea of what the extent of that soft tissue component is. So when you move from here to here, you've seen that your understanding of this lesion has changed dramatically in terms of getting a sense for what this lesion is and what you're dealing with when you're planning to go and intervene on this. Here again, our MR will show you very nicely the extent of disease. This is the superiormost extent. This is the little marrow edema that's extending beyond the lesion, and the extent of cortical destruction as well. The other thing that MR will do for us, it will give us a great idea of the involvement of the adjacent structures. So invariably when you're going into large complex lesions, you want to know what the status of the adjacent neurovascular structures are. What is the degree of involvement of these structures? How many of these you may or may not have to sacrifice? And accordingly inform the patient as regards what they can expect from the surgery. So with newer and higher resolution MR imaging techniques, we can tell very nicely, here's the sciatic nerve in the pelvis running along the undersurface of the tumor here. You can see the fat plane is really nicely maintained between the tumor and the sciatic nerve, and there's no encasement. And again, this is a case in point where the imaging modality or the sequence really makes a difference. So on this STIR image, we see this large tumor. We see a lot of fat stranding here. We see a lot of edema and fat stranding along the nerve itself, and it's nearly impossible to tell whether the nerve is encased or not. Whereas when you look at this more T1 or proton density weighted image, you can see that the tumor is here and the nerve is very clearly spared. So again, it's important to look at these various modalities when we're looking at this. Now, what I want to see if we can do from here, I don't know, oops, sorry. Keys. Oop, that's not good. Sorry about that. No, this is purely put on PC, so I didn't. Let me go to slide. Sorry. So what I wanted to show you here is something that we've been doing. You can do MR angiography, which allows you to see the vessels really nicely. And now with some nice fusion imaging software, what we're able to do is take the MR angiogram, which is just basically an image of the vascularity, and you can fuse it with the regular image and get a really nice, very clear appearance of what the vessels are, where they're tracking in relation to the tumor, and how they're being involved or encased by the tumor. And we can do this in multiple planes, and for those who really want this documented nicely, this is certainly something that we can demonstrate for you and show you with some really cool image processing tools. So I think this is another area where using multimodality imaging is very helpful in understanding where the lesion is, how the vessels wrap around this lesion itself, and then again the enhancement pattern of the lesion itself. Okay. Here again is an image where we've just fused, essentially this is the angiographic image. We've just fused it over one of these images, and you can see the blood vessels in orange, and they're just sort of lighting up brightly, so you can tell what the involvement of these vessels is. So once we move on from sort of identifying where the lesion is, the extent of the lesion, the structures that it's involving, we move on to the next thing in terms of what is the nature of that underlying tissue. And when we look at the nature of the underlying tissue, the things that we're asked is, what is the proportion of live tumor cells in this? Is there necrotic tumor? What is the reaction around the tumor? And what we want to try and identify here is what is the predominant cell or structure or content of this lesion. We want to understand the interplay between the tumor and the adjacent tissue. We want to know the common locations and reactions associated with certain tumors, the vascularity of the lesion, and then finally looking at things like metabolic imaging, which I think Dr. Krishna will discuss in more detail. So just when we talked about, sort of identifying or characterizing the contents of a lesion, this is one of the areas that ultrasound plays a really, really nice role for us. And one can see very nicely here that when you have these hypoechoic structures, they have no echoes. The echoes around are very good over here. Basically, the sound waves travel very quickly through the fluid, and so you don't get any resonating echo back. So these come as very hypoechoic lesions here. These are typical for cystic lesions, and this is just an example of a ganglion cyst communicating with the scapholunate joint, and you can see a scapholunate ganglion cyst over here. So you can tell that this is clearly a cystic lesion, and I find this very helpful, especially in our country, where you do an MR scan, the contrast is going to cost you 3,000 rupees, and you have a fairly small superficial lesion, and you want to determine whether this is going to be cystic or solid. An ultrasound is a great tool when it's superficial. You just put the probe over it, you know it's cystic, and then if you're sure about it and you've discussed it with your orthopedic oncologist, what you can do is actually at a cost that's lesser than doing everything together, put a needle into it, aspirate it, or biopsy it. so that you can actually get tissue sampling simultaneously. Here's a lesion where you can see within the cyst that there's a cystic structure here, and this is an example of cysticercosis, so you can further characterize some of these lesions. Here you can see a lesion that's solid appearing, but you can see very nicely how the solid appearing lesion is communicating with the nerve, so you can tell that it's a tumor of nerve origin. We can tell vascularity, or you can see these venous vascular puddles in it. You can turn Doppler on with it. You can see the flow within it, and you know that this is a venous vascular malformation. We can tell, again, this is just a large intramuscular hematoma, and more venous vascular malformations. Again, slow flow venous vascular malformations. You can actually tell small little echogenic foci within it, which are the calcifications within these lesions. So essentially what we can do with ultrasound is we can determine whether lesions are cystic or solid. We can determine whether they are vascular or non-vascular. We can sometimes determine what structures they arise from when we do higher resolution imaging. So it's a really, really good tool that's available. And if you can see these lesions, what you see is this is the skin surface. So it's very easy to put a needle into this lesion under ultrasound guidance. You're 100% sure you're within the lesion, and biopsy and sample this lesion as well. Lipomas are another lesion that we can see. These are sort of echogenic in appearance, and sometimes can blend with the fat. They can be sometimes difficult to identify. But again, since you're doing an ultrasound, you know exactly what the patient's bump is, and you can identify that area and scan over that area specifically and tell that a lesion is a lipoma. So again, when we move from that aspect of ultrasound, MR has another role that it can play in these lesions. And what MR does is we can use various sequences that allow us to differentiate fat from water. And what we're doing in lesions like this is you have this large intraosseous lesion that's non-aggressive appearing, got a few calcifications within it. On this T1 weighted image, you can see the entire marrow fat is bright. You can see the lesion is also bright, and it's got this central sort of irregular area. But on a fat-suppressed image, you can see the entire lesion suppresses out, and this is an intraosseous lipoma. So we can tell the content of, whether the lesion consists primarily of fat or fluid based on MR. We can also see these lesions, which can often be, a lot of people can be fooled by, where you see these cystic lesions, they're low signal on T1, they are bright signal on T2, and they have peripheral enhancement, but they also have this heterogeneous heterogeneous signal within them, which is pretty common for something called for a myxoid lesion, and this is a myxoid liposarcoma. So in these cystic lesions, it becomes very important to give intravenous contrast or to assess them in some other way to ensure that there is no solid component to these. Other ways that we can characterize lesions are based on the presence of fluid levels. And while we do see fluid levels in simple aneurysmal bone cysts, we can also see them associated with giant cell tumors. And then in some cases, we can also see fluid levels associated with telangiectatic osteosarcomas. So it's again important to not just jump to the aneurysmal bone cyst diagnosis every time you see fluid levels, but to sort of go that step further and determine if there's a solid component to it, and then determine whether that solid component is more in keeping with a giant cell tumor or a telangiectatic osteosarcoma, which you will often be helped with by just looking at the plain radiographs. The specific location of soft tissue lesions can often help us. A juxta-articular location of a solid appearing tumor is very typical for a synovial cell sarcoma. We can also look at these lobulated lesions like this. When you look at this lobulated lesion, it just appears like a lobulated, variegated lesion, which is pretty typical for a vascular malformation. But if you're looking for that one extra clue that will throw you in towards being a venous vascular malformation, you can see that this lesion, this is a gradient echo image, which has more propensity to have artifacts. Artifacts are produced by calcification within the lesion, and this calcific focus becomes very prominent in these lesions, and this is fairly typical for a venous vascular malformation. So again, another way to help characterize the contents of a lesion. So once we have characterized these lesions, we use various techniques. Obviously, we can use an understanding of what the basic cellular content of these are. They fluid containing? Are they cellular, or are they containing? Do they contain lipid tissue? We can also use the location and the other parameters that we know in terms of identifying these lesions. But sometimes, and oftentimes now, we want to go that step further. We want to see if we can understand the cellular dynamics, or what is the cellular content of this lesion at a greater level. And in these, while we can use molecular imaging techniques, the other ways that we can use things are by looking at things like in and out of phase imaging. This tells you whether or not there's presence of fat within a cell, and this is very helpful in determining malignant from benign osteoporotic compression fractures. We can use things, and this is my colleague in Mumbai, Bhavin Jankaria, he uses a lot more of this dynamic contrast imaging, where looking at the rate of vascular enhancement within the lesion and the rate of washout in the lesion can give you clues as to what the content or what kind of lesion you're dealing with. We can use diffusion-weighted imaging, which is basically a method by which we're looking at the mobility of water molecules within a structure that would determine what a lesion is. And what we had done when we were looking at spine images was you could see that the rate of diffusion was significantly higher in acute benign compression fractures, intermediate in malignant fractures, and very flatline sort of in control or benign fracture or in chronic fractures. So again, looking at diffusion values may be of some assistance in understanding sort of what the role of whether things are malignant or benign or what the cellular content is. Finally, people are looking at MR spectroscopy. We can look at actually the concentrations of various chemicals within a given cell or voxel using MR spectroscopy, and an increase in the choline and lipid peaks can be seen with malignant lesions. Increase in the lipid peak alone can be seen with benign lesions. And I think these are more sort of experimental. They're helping us to understand tumor biology a little bit more. But I think as we learn more from the pathologists and from the molecular imaging groups, we'll be able to apply some more of these techniques in MR, CT, and ultrasound. In terms of quickly about follow-up, we can obviously see that while on both these studies, the image or the tumor itself appears fairly symmetric in size, what we see is a change in the vascular enhancement pattern of this lesion, indicating there is some intralesional necrosis. So this is something we can do with follow-up studies. We can oftentimes see bone edema here, and a lot of people just sort of equate bone edema to presence of disease, which I should discourage all of you from doing. You need to determine whether something is truly bone edema or it's actually just infiltrated with disease. And here's a patient who has surgery for a giant cell tumor. You can see bone edema in the lunate and the scaphoid. Somebody might say that there's additional disease in here. You can see on a follow-up scan how that bone edema and everything has resolved. It's just reactive bone edema. Finally, I like the slide that Manish and I worked on together. It's this concept that everyone has that you can't put metal into an MR scanner. We put metal into MR scanners every day. Orthopedic implants are extremely robust. We have imaging techniques today that we use to image joint replacements. So, imaging rods and smaller things is really not that hard anymore. And what we had over here was this case that was, it was a fracture through the midshaft of the femur that was treated with an intramedullary rod elsewhere. They didn't do a biopsy. It turned out to be a malignancy. The guy comes back with a massive mass. And when I saw it, I mentioned to Manish, I said, Manish, I bet you we can look at this with hardware imaging and tell you where the tumor is going. And so we said that there's obviously tumor here, but we could see it tracking all the way along the nail, coming all the way up to between the first and second interlocking screws. And Manish was kind enough to do this when he was at surgery, where he showed the entire intramedullary rod, and you can see the tumor extending all the way up to exactly the same spot. So even with metal imaging, there are some limitations. There are a lot of read-arounds, but we can give you a lot of information in these situations as well. So just quickly, you want to consider CT when you're not sure of the nature and extent of bone interactions. You want to see if there are calcifications a little bit more closely. You want to assess the vessels. If there's already an MR done, you want a slightly cheaper alternative. You could consider a CT angiogram to look at the vessels. You want to assess hardware. Sometimes the streak artifact is too much with MR, and you can't look at it well, so you want to look at that. And obviously CT-guided biopsies. For superficial lesions, you should have a good sonologist available with you. I think you build these by regular interactions with them. It can definitely help you with cystic versus solid lesions. It can help you in situations like lipomas, and it's extremely useful for ultrasound-guided biopsies. MR, I think the things we want to just inform most people here, since it's probably the most easily available and most used test after a radiograph, is T1 is generally good for anatomy and differentiating tumor from edema. T2s are good for fluid or solid and cellular masses. T2 with fat suppression will make lesions far more conspicuous. And contrast is helpful, but not really always necessary. So it's good for assessing the extent of disease in bone and soft tissue. It images you must ensure that you inform the imaging centers to include the entire bone in its entire length to look for skip lesions. You can use it for follow-up after treatment. We can use it in metal imaging. And many of the advanced techniques like spectroscopy, diffusion-weighted imaging are hard to replicate and are still in their experimental stages. So finally, just a quick summary slide. We want to use advanced imaging when you want to increase the conspicuity of a lesion, you want to improve the assessment of your extent, you want to try and characterize the contents of this lesion, you want to get a sense for lesion aggressiveness, you want to improve biopsy yield, and you want to do sort of an in vivo follow-up so you don't have to open up and find where these lesions are. And there are some interesting tools available now for post-operative imaging well. So thank you. I'll stop with that.
I can see scalloping a lot better on a CT scan than I can on a MRI scan. So I commonly use it for that. Osteoid osteoma. I think osteoid osteomas are more difficult with the MRI scan. You see a lot of bone edema, but you can see the nidus a lot better with a CT scan. So I think there are certain tumors that the CAT scan will help me out, and I T1 weighted image the marrow extent, and then on the contrast enhanced image, the soft tissue extent.
If that be the case, from a cost-effective
Sarcoma, I need to do that CT scan because if there's grade 1 scalloping, I'm not going to biopsy it, I'm just going to follow it by x-ray. If there's grade 3 scalloping, I'm very concerned that's a malignant tumor, and I could even just go right to a resection and not even do a biopsy on those. So I think that depending on the type of tumor that you're dealing with, my own perspective is that most of the time we can do a biopsy off the x-rays. Many of these advanced imagings are surgical planning ones and probably don't have a lot of effect on my differential diagnosis.
Well, I just want to add one thing is because when we send the patient for an MR or because very often surgeons who are first.
So there's a lot of value in a malignant tumor for doing an MRI scan up front, and then you can actually predict your necrosis and how well your treatment's going as you move along.
Your other question about doing a biopsy.
No, actually what, sorry, I know the utility of CT and
And shouldn't be mistaken for spread of disease over it just being edema.
That becomes very important of that thing because once you do an MR post-treatment, it will change everything. Then you don't have baseline MR,
Right.
which was not done without
Right.
biopsy.
Right. No, so what we,
I would actually disagree on that, and I would say that you do the advanced imaging, the basic imaging first before doing biopsy.
absolutely. I mean, this is exactly what everybody here, and it's just that if we look at everybody's, on this side, the practices, most everybody's dealing with tertiary care practices, and I know Manish will get a smaller proportion of virgin tumors as compared to Doug, just because everything's already come worked up with things stuck into it and everything else by the time you get to it. So I think that.
Is it a benign periosteal reaction or a malignant periosteal reaction? That's what's important because it is too often misinterpreted. As soon as they see a periosteal reaction, it must be a malignant tumor, and that's throwing many of the orthopedic surgeons off. Following that, they see that periosteal reaction and think it's a malignant tumor, and then they inappropriately manage it. So I'm not so sure it's really important for everybody to know the specific classification as we presented it. I think you need to know the difference between a benign periosteal reaction and malignant periosteal reaction. The problem is there's not been any papers written on that. We've been researching it. It's been Codman and Drysdale's theories for years, but nobody's really talked about the difference between those two. And also, I think with CAT scans and MRI scans, we're actually defining that periosteal reaction even better than we are just plain X-ray.
And we're not even, in terms of periosteal reaction today, you may not see periosteal reaction on a radiograph, but you'll see periosteal edema on an MR, and that actually qualifies as being periosteal reaction. So much subtler. But the other thing, sorry, about the ACR guidelines, I think, is that the ACR guidelines are one, guidelines, and two, they are minimal competency. So I certainly don't think one should necessarily hang their hat on what the ACR says as far as it's just enough to document that there is periosteal reaction.
Paper in the ACR 2008, and it just, the whole essence of that paper is on periosteal reactions, and the whole essence of the paper is to just identify periosteal reaction. I do agree, you do need to make a differentiation between malignant and
Right.
Just a question to you, so how many percentage of your osteostomas do you do an MRI on? Because that's another conventional teaching that you don't need an MRI. It's basically CT scan.
That's what actually everybody, what the purpose of this course is, I I think to start getting everybody who is in general orthopedic practice to start at least following some basic guidelines to run things so that at least things are worked up in a systematic manner.
Well, and I think, especially now in the U.S., now that Obamacare is in place, we have to really be much more concerned on cost than we ever have. And we can save enormous amounts of radiology costs because in the United States, it's predicted 60% of radiology costs are not necessary. So we could save a lot of that if at any time that the neoplasm is suspected, if they just had it reviewed, like we have a radiology conference every week, people just send us x-rays and we review them, that we can make recommendations. We can eliminate so many tests because there's a knee-jerk reaction. Somebody sees a neoplasm or a suspected neoplasm, they just order MRI scans and then more MRI scans, and they don't even know how to work it up when actually a CT scan on osteoarthritis would have given you the diagnosis. And so I think we would save a lot more money if the specialty centers would be making the decisions on what tests to order, or trying to teach more people how to order those tests, but somewhere along that way.
So,
One technical question. We are now getting a lot of digital X-rays.
Make a diagnosis, because by minimizing the tests, you're not going to pick up the details to make the diagnosis. And so I think bone scans are a good example. People are doing bone scans, and they'll do a bone scan of their finger, you know, and then you don't see that this guy has Olliers disease because they didn't do any of the rest of their body, you know. And so, you know, every time we image, it's a total body bone scan. I don't care. I know what the image is going to be of the lesion I'm looking for. I'm looking for the rest of the body. And same thing with PET scans. I mean, it turns out there's a lung cancer. You would have seen